Hi, good morning everyone. My name is Abdullah. I'm currently a fourth year medical student at the University of Sheffield. And I had the opportunity to spend 6 weeks on the cardiothoracic unit at the Northern General Hospital in Sheffield as part of a student selected component. And during my time, I was able to organise a short audit looking at malnutrition screening in patients undergoing either cardiac or thoracic surgery. So why do we look at malnutrition? It's quite a pertinent subject at the moment, especially with the previous discussion that we've just had in terms of surgeons' mortality data being published. And it's quite important that any factors in patients' outcomes are controlled. And there's been a lot of research ongoing into malnutrition and outcomes in terms of surgery. And it's quite important to identify patients that may be at risk in order to prevent post-operative complications. So there was a study that looked at just over 5,000 patients receiving either bypass grafts, valve surgery, or both procedures combined. And those patients that were underweight, so with a BMI of under 20, actually had a significantly increased risk of various outcomes such as cerebral vascular disease, vascular accidents, renal failure, reoperation for bleeding, and that was in comparison to those with a normal BMI. In terms of the thoracic side, so similarly, those receiving lung volume reduction surgery, 26% of patients with a low BMI compared to those with a normal BMI required ventilator support for longer than 24 hours. And then looking at weight loss in itself outside of BMI, so having an unintended weight loss of more than 10% in 6 months, in 3 to 6 months actually, in the run-up to surgery was linked to a significantly prolonged hospital stay, and that comes with its own problems. NICE has issued some guidance on this, and it states that all patients, whether they're being admitted or outpatients in clinics, should be screened for their malnutrition. And a malnutrition universal screening tool, or otherwise known as MUST, could be used to do this. Additionally, patients who are inpatients should be screened on a weekly basis to assess their progress. So what is MUST? It's a really easy to use 5-step screening tool, and it's there to identify patients that are either currently malnourished or at risk of malnutrition. Step 1 requires you to work out the BMI. Step 2 requires you to work out any unplanned weight loss in the previous 3 to 6 months. You then establish any disease effects, so whether they're acutely ill currently or if there's any chance of them not receiving nutrition for at least 5 days. These are all scored, and this is all added together, giving a score either 0, 1, or 2. And that corresponds to a low risk, a medium risk, or a high risk. And then it also gives management guidelines depending on the score. So for low-risk patients, they just need to be screened routinely, so on a weekly basis. If they're at medium risk, you should document their dietary intake for 3 days and then regularly screen them. If they're at high risk, so if they're scoring 2 or more, they require treatment, so refer to a dietitian or the nutritional support team. And there's usually local policy in place in how to manage these patients. So in terms of the study itself, we looked at patients that were either being admitted for cardiac or thoracic surgery on the cardiothoracic unit. Data was collected over a 2-week period, and it was done by looking at patients that were being discharged on the day of data collection, just because it meant that they had a complete set of records. Within this, the observational charts had a core risk screening assessment booklet that was used at the trust, and within that was the MUST screening performer, and this was appraised to see whether or not MUST screening was performed to adequate standards. And then if a patient had a score of more than 1, the medical notes were reviewed again because documented action should have been placed in the notes whether or not they were scoring. So we looked at a few parameters, so patient demographics, we looked at the 3 gold standards that NICE has outlined, which were MUST screening should take place in pre-admission clinic. It should then take place on admission, and then weekly during their admission. And then again, if they had any evidence in the notes of action being taken place, so whether they were referred to a dietitian or a nutritional support team, and whether or not their frequent weights were taken on a weight chart. And a total of 54 patients were included in the study. So we had quite a range of patients age-wise, the youngest patient being 32, and the average age of patients was around 67 years. Majority of the patients were male, with only 12 patients in the study out of the 54 being female. And cardiac surgery was a prominent caseload for the patients in the study. 15 of those out of the 40 were for bypass grafts alone, and 8 admissions were for a VATS lobectomy or a wedge resection. And a majority of the surgeries were taken electively. There was only 9 emergency admissions, and 8 of those were actually for cardiac surgery. And there was quite a range of length of stay. It went up to just over 16 days, and the shortest stay was just 1 day post-operatively. There's quite a range of BMI as well. So for the patients who were actually successfully screened, most of them sat between 20 to 30 on the BMI range. There was quite a few that were known as clinically obese, so having a BMI over 30, but the average BMI was 29, so just under being obese. One patient was quite underweight at a BMI of just under 18.5. So these are the results of the actual study. So the 3 main gold standards were that 100% of patients should undergo screening in pre-op assessment clinic, then again on admission, and then weekly during the admission. So compliance should be at 100%, but none of the screening actually hit 100%. It was always lower. So in pre-assessment clinic, just under 3/4 of patients were screened correctly. There was quite a disparity between cardiac and thoracic patients, and for some reason the cardiac patients were screened more often than thoracic, and this was a recurrent feature. It kind of tapered down throughout the patient's progress, so when they then were admitted to the ward, only half of them were screened, and then subsequently only 1/3 of patients were actually screened weekly during their stay. Unfortunately, on the thoracic side, none of the patients were screened weekly, and 12 of them were eligible where they had a stay of longer than a week. Only 3 patients were identified as having a MUS score of greater than 1. However, only half of them were actually screened on admission, so there could have been potentially more that were missed. And of those that had a score of 1 or more, only 1 patient had documented evidence of action in the notes that a nutritional support team or dietitian had been involved. And in terms of weight being recorded on a daily chart, only 4 patients out of the 54 had this done for them. Whilst I was on the ward, daily weights were being taken, and these would kind of just be scribbled on the margins of the observational sheets and lost at times, when there was actually quite an easy-to-use proforma attached to the MUS proforma where weights could be recorded, and it gives a really nice graphical sort of view. But this wasn't used at all. So just to summarise again, we looked at 54 patients over a 2-week period. Almost 3/4 of patients were assessed pre-assessment clinic, a half when admitted, and then only 1/3 weekly during admission. So it kind of tapered down during the patient's progress during their stay. And I guess we highlighted like a stark underuse of the malnutrition universal screening tool during a patient's stay on cardiothoracic surgery. There's a few recommendations that arose from this. I think starting from education to ensure that all staff were aware of the MUS tool and how important it is. Additionally, highlighting when they should be screened, so the 3 stages when patients should actually be screened. I think importantly, identifying any resources that might not be there, so measuring equipment or scales, and improving access to these to ensure that nurses are actually able to screen them when they need to, because they can be quite busy. And then also highlighting any alternative measurement techniques, so using ulnar length or knee height to approximate a patient's height, or their mid-upper arm circumference for approximating their BMI range. It's quite important where patients may be bed-bound post-operatively, they can't mobilise onto scales, so this is a good way to monitor their progress. And I think, as I mentioned before, demonstrating the use of the weight chart as a convenient location to record a patient's weight progress, particularly post-operatively. And then following this to re-audit, and that is the plan at the moment, to re-audit having implemented these changes. Some references I used. Thank you.